Concern. Hello. Sir, you have to mostly have a look at a YouTube. Have a check at a YouTube link. Mostly it's not coming in a previously. Hello. Am I audible from OT? Am I audible from OT?
Yes, sir.
Okay. So very soon we are going to start the next case. It is the last case of today. And before the case, mostly before the case, Rohan is going small presentation on CTPNS. Abhinav, are you in the auditorium? Can you start now or
Yes, I'm here.
okay?
We can start. We can
All
start.
have a lunch.
Yes, everyone has a lunch, so we can start.
I think the auditorium is little bright. You can put off the lights.
Yes.
And who is the moderator, Abhinav, for this session? May I know who serves? Yeah.
Sir, for the next session, I'd like to invite Dr. Bhavin Chaudhary sir and Dr. Khan sir to just chair this session.
Good afternoon, and may I request Dr. Rohan to start his presentation on CTPNS.
Rohan, please.
Hello. Counselor.
Yes, we can hear you. We
Okay.
can hear you. But your presentation is not come up on the screen. We do not see your presentation. Yes, we can. You can start.
Good afternoon, all my teachers and colleagues. Today we will read through a CT scan of paranasal sinus, touching upon the important landmarks without going into too much of theoretical details. We usually give the CT scan of PNS for diagnosis of sinus disease and one diagnosed and taken up for surgery. It is extremely important for planning of the surgery as it gives us the information about various structure and give us a roadmap for safe surgery. So before going to the CT scan, first we'll come for the patient's preparation before sending for a CT scan. One full course of proper antibiotics should be given. Continuation of all the oral antihistaminics should continue. Nasal decongestant packing 15 minutes prior to the imaging, which is followed by vigorous nose blowing. In case of allergic patients, steroids should continue. What are the important radiological landmarks that should note in a CT scan? Relationship of the cells within the frontal recess and their relationship to the frontal sinus. Depth of olfactory fossa, slope, thickness, and asymmetry, height of the ethmoidal loop, patency of the osteometal complex, attachment of the middle turbinate, vertical distance from maxillary sinus to posterior instrumental roof, degree of pneumatism of maxillary sinus, status of lamina propria, attachment of the uncinate process, alignment of the nasal septum, size and status of maxillary sinus, and other variations like presence of concha bullosa. So, we'll come to how to read a CT scan. The first cut, which is also known as a scout view or a gantry view. This cut is very important because it helps the surgeon assessing the position of the patient, the window setting. Either it's a bone window or a soft tissue window, size of the cuts, and exact location of the cuts. So, this is the CT scan of today's case. So we have asked the radiologist to give in a DICOM format. And this is a Radian software where whenever we ask for a CT scan in axial cuts, we can reconstruct into coronal and sagittal plane. So let me reconstruct to coronal plane. So if we'll go from anterior to posterior, so first thing we'll see the nasal bone and a soft tissue shadow here, which is nothing but skin of the forehead. If you go posteriorly, you can see nasal bone here, and the frontal bone started appearing. If you go far posteriorly, you can see pneumatism of the frontal bone, which is a frontal sinus. We are going far posteriorly, we can see two frontal sinus appearing with a intersinus septum in between. And in the right side, we can see a incomplete septation in the right side. This is the frontal process of maxilla, and the maxillary crest started appearing. If we go far posteriorly, the frontal process of maxilla thickened to form the frontal beak, and the frontal beak forms the floor of the frontal sinus. This is the frontal beak, what we can see, and this is the frontal sinus. This is the right side frontal sinus, and this is the left side frontal sinus. Here we can see the perpendicular plate of ethmoid, and this is the septal cartilage, this is the LL cartilage. We are going far posteriorly, we can see there is a deviation here in the nasal septum, and this is the thickening of the quadrangular cartilage. Still we can see here, this is the frontal sinus opening because the frontal beak is still intact. We are going far posteriorly. Here, the first cell which appears is the agar-nasal cells. And as soon as the agar-nasal cells appear, the frontal, you can see the beak is not intact. So, this is in the right side, this is the posterior end of the frontal sinus. And this is the frontal recess, where the frontal sinus drains. So, let me show you in the sagittal cut. This is the agar-nasal cells. So during the endoscopic sinus surgery, which is attached to the anterior wall of the frontal recess. So during endoscopic sinus surgery, with the help of 70-degree scope, we have to go posteriorly and flexure it outside, outwards. So you can see here the attachment of the, this is the agar-nasal cell. If you go far posteriorly, you
Rohan,
can,
at this level, you can also see the lacrimal sac.
yes sir. So, yes sir, I'll come to the lacrimal sac. So there is two ways to identify the lacrimal sac in a CT scan. So the first thing, you have to follow the frontonasal process of maxilla from anterior to posterior. So if you'll follow the anterior frontonasal process of maxilla, if you're going posteriorly, you can see the lacrimal sac, which is opens into the inferior meatus, which is guarded by the Hessen's pulse. And one more way to identify, there is lacrimal sac appears just after the agar-nasal cells. One cut posterior to the appearance of the agar-nasal cell. So I'll come to the classification of the frontal cells. There is two classification. The anterior to the nasofrontal drainage. This is the old classification, which is Kuhn cell and agar-nasal cells. And posterior to the nasofrontal drainage, suprabular, frontal bular, supraorbital ethmoidal cell, and intersinus septal cell. What is Kuhn cell? There is 4 types of Kuhn cells. The type 1 is single cell above the agar-nasal. Type 2 is 2 or more cells above the agar-nasal cell. Type 3 is single cell extending from the agar-nasal into the frontal sinus. And the type 4 is an isolated cell. So this is the cells which is attached to the posterior wall of the frontal recess. So what is the importance of this cell? I mean, in the CT scan, if you find a suprabular cell or a frontobular cell, so what we have to do, like as I said, for an agar-nasal cell, we have to go posteriorly and break it outwards. But for the cell which is attached to the posterior wall, you cannot go from the behind because it will lead to the CSF leak. So what we have to do, we have to just break the cell wall and flush with the skull base. So I'm coming to the newer classification of frontal cells. They are classified into the anterior cells, posterior cells, and the medial cells. The anterior cells is classified into agar-nasal cells, supra-agar cell, supra-agar frontal cell, posterior cells, which is classified to bulla ethmoidalis, suprabular cells, suprabular frontal cells, and supraorbital ethmoidal cells. And the medial cells are the frontal septal cells. So I'll come to the diagram now. Okay, now I'll come to the middle turbinate, the attachment. The middle turbinate, it has a 3 parts, which is attached to the, first part is attached to the skull base. You can see here. The second part, which turns laterally and attached to the lamina papricia, which is also known as ground lamella. And the third part, which is attached to the perpendicular plate of palatine bone here. So, coming to the frontal cells now, this is the agar-nasal cells. We are coming far posteriorly. This is a supra-agar cell according to the new classification, and we are going far posteriorly. So there is a confusion. What is this cell? It's a frontal recess or a frontal cell or what? See, here we can see properly the maxillary sinus, and the cribriform plate is properly seen. So it is nothing but a supraorbital cell. Now coming to the uncinate process, I'm coming from anterior to posterior. In this case, here is the inferior turbinate. This is the uncinate process, which is going up, going medially of the agar nasal cells, and it's attached to the skull base. The uncinate process, it has three attachments. In some cases, it attaches to the lamina papyracea, some cases to the skull base, and in some cases to the middle turbinate. So in this case, the frontal sinus, it drains into the infundibulum. You can see the pneumatization of the middle turbinate. This is called concha bullosa. Now we are coming to the what type of skull base is this? This is the medial lamella, this is the lateral lamella. So this is the depth of the olfactory fossa. The Quiros has classified it into three classifications. This is the cribriform. Type 1 is 1 to 3 mm, type 2 is 3 to 4 to 7 mm, and type 3 is 8 to 17 mm. Sir? One minute, sir, I'll do that, sir. This is the 4 mm, so this is the type 2 of Quiros classification, sir. So I'll come to the now I'll come to anterior ethmoidal artery. So how to identify the anterior ethmoidal artery in a CT scan? So this first thing, this is the bulla ethmoidalis. So bulla acts as a bodyguard to the anterior ethmoidal artery. So anterior ethmoidal artery is just few cuts behind the where you can see the bulla ethmoidalis. The second thing, you have to see the 1 minute. I'll show you the ground lamella. The anterior ethmoidal artery is few millimeters anterior to the ground lamella, and in the axial cuts. Yes, sir. You can see the ground lamella here. So anterior ethmoidal artery, you can see the peak here. This is the peak here. This is called Kennedy's nipple. So it exists from the orbit along with the it exits the orbit and it enters the cranium and it gives a Falcine artery branch here. It comes inside the nose. It supplies anterior frontal, lateral wall of the nose, part of the septum, and it again goes out through the nasal. Then coming to the how to identify CT changes when we goes from anterior to posterior ethmoids. So, like I'm coming from the anterior ethmoids. You can see the orbit, which is spherical. Once we go to posterior ethmoid, the orbit becomes conical, and the size of the orbit becomes smaller. The second point is the maxillary sinus, which is triangular in the anterior cuts And when it goes to posterior ethmoids, it's become oval. And the skull base, which we can see in the anterior skull base, which is sloping and thinner, and the posterior skull base, which is thicker and which is flat. Now, we're going far posteriorly, so we can see this is the posterior ethmoidal cells, and how to differentiate the posterior most ethmoidal cells from the sphenoid sinus. So usually this is the bone we have to just follow. It extends. This is the frontal bone which extends from one pteridion to the another pteridion. Once we enter sphenoid sinus, this bones breaks here, and this is in the left side. This is the sphenoid sinus, and in the right side, it's still the posterior most posterior ethmoidal cell. So we are coming to the proper sphenoid sinus. This is the
Clinoid process. Clinoid
this
process.
is the clinoid process.
Hello, you wanted to show us the foramen oval and rotundum, probably?
Sir, just a minute, sir. It's getting stuck. Just a minute. This is the Virian canal, and this is the foramen rotundum. We are going far posteriorly. Here we can see foramen oval here. Uh, sir, this is what we can see in a coronal cut, sir. I'll give it to Mr. Sir, for the.
Thank you. Thank you. Very nicely demonstrated. Nice.
Counselor,
Yes, sir.
am I audible?
Little faint, little louder.
Yeah. Now,
Yes, better.
thank you, Rohan, for your elaborate description on CTPNS. But I'll try to, sir, this case is reduced, and Hemanto is going for giving the PEG, and I'll go little simplify version. Actually, how I actually read CTPNS in a very simplified way. So we prefer always a cornell cut, as I know, and as Ruhan has already explained from most, I'll not go details that much. So in this case, what we can appreciate is that nasal bone is the frontal sinus, and why it is a frontal sinus? Because it appears before the starting of the middle turbinate, and you can appreciate there is a gross DNS with a gross deviation of the maxillary crest, particularly the floor area. And this is the maxillary sinus appears now, and this is the most important landmark now. This is a frontal brick, because still we have not seen the attachment of the middle turbinate, and we have not seen also the maxillary sinus. So that's how this is a brick. This is the frontal nasal process of the frontal bone, and from that area you can now the appearance of your middle turbinate. As Rohan has says, this is the appearance of the agar nasal cell and middle turbinate, and if you can appreciate the frontal drainage pathway is lateral to the middle turbinate here. And he has already mentioned all the new classification, how we can appreciate. Actually, I have a little simplified simple presentation for today's actually. Just a minute. It's called new learning. I have termed the new learning for the preparation of basically this workshop.